Before we shift into actions, let's get a summary of what's been captured by Trent Wakenight for the panels. Then we'll move into hearing from the floor what actions your organizations are taking in this space. Trent, how would you summarize?
Thank you, John. I'm Trent Wakenight from the Grove Consultants International. I created the graphic recordings that you saw during today's panel discussions. One theme that Stephen Sidney shared in the fifth signature report was the exacerbation of cardiovascular disease by COVID-19. The collision of these pandemics is most acute in Hispanic and non-Hispanic Black Americans. Dr. Sidney reminded us of the importance of vaccinations, and by preventing the impact of one, we are preventing the other. Disparities, unfocused spending, and the mobilization of community resources were acknowledged by Panel 1. There's life-saving value in recognizing public health's community mission. Polling and data analysis can drive a more thoughtful prevention agenda and targeted messaging, as we heard from Panel 2. Trust can winnow away cynicism when we communicate using the right messaging, preferred channels, and a broad mix of mediums. We also need to show people the impact that they are making in preventing disease. Mayor Frank Scott Jr. highlighted efforts in Little Rock to shape a business case for investment in tackling social disparities and barriers to health. Meet people where they are, share the why, and listen too. Mental health plays a role in physical health and cardiovascular disease, as pointed out by Panel 3. Dr. Melnick and Dr. Woods-Giscombe identified the value in equipping all health practitioners to implement mental health behavioral education and interventions. Cardiovascular disease is preventable, and it can be influenced by our mindset and use of mindfulness practices. Thank you to our fantastic panelists and moderators and my opportunity to visualize your talks. Back to you, John.
Thanks, Trent. Great summary, and appreciate the visuals. Now, let's amp up the interactivity. As I mentioned at the opening of the meeting, this is the time for National Forum members to share actions that they're taking or will take to carry out the charges from any or all three of the panels. This is a lightning round. Each person has a maximum of 2 minutes. We have several members already in line. If you want to give an action report from your organization, please use the Q&A feature to get a place in line. To lead us off today, we have Sue Koob, Executive Director of Preventive Cardiovascular Nurses Association. Sue?
Great, thanks, John. Can you hear me?
Yes.
Hi, everyone. Thank you so much for this opportunity. I am Sue Koob. I'm with the Preventive Cardiovascular Nurses Association. First, I really want to thank the National Forum for just an incredible and informative, engaging program today, and really to all the amazing speakers, as these discussions have been really inspirational. As you know, I was asked to give a quick update on how PCNA has or plans to take action on some of the issues that have been discussed today. We as an organization really focus on education and partnering with key organizations. So we have a lot going on, but I'd love to highlight the fact that, we continue to partner with the National Forum, Patch, and others on exploring ways to ensure increased access and understand really what value means in terms of CVD prevention. We're very excited to be working closely with the CDC, Mending Hearts, and other nursing organizations and institutions to publish a call to action paper on the role of nursing in hypertension control. We have 2 COVID and CVD sessions planned at our annual symposium next year, as well as multiple sessions addressing health inequities. We are also partnering with multiple nursing organizations, including the American Nurses Association and the National Black Nurses Association, on the health of nurses, Healthy Nurse, Healthy Nation, including really addressing mental health and stress. And lastly, I'd love to mention we have an amazing project underway with the Association of Black Cardiologists on addressing health inequity. It's a two-part project to educate both legislators and healthcare providers. If anyone on the call today would like to join us, the Healthcare Provider Health Equity Summit is going to take place next week on Tuesday and Thursday. You can register at pcna.net. So, John, thank you so much for this opportunity. It was great to have the chance to share what's going on with PCNA.
Thank you very much, Sue. And I've signed up for the Health Equity Summit, and I encourage others to do so as well. It looks like it's going to be a very important and very meaty program. So I'm so glad you and ABC are collaborating to put that on. Our next update, our next action report will come from Dr. Janet Wright, the Director of CDC's Division of Heart Disease and Stroke Prevention. Dr. Wright?
Thanks so much, John. I'm looking at the clock. Let the clock start. Thank you all for a chance to join today. I learned so much. And so I want to share with you the commitments from the Division for Heart Disease and Stroke Prevention. It's my honor to represent that wonderful group of people. As you all know, because Darwin Labarth founded this division's always been focused on health equity and reducing health disparities. It has grown in that mission over time through other leaders and the staff, but now we are building on that foundation, and we're going granular. We're taking advantage of this wonderful opportunity presented to us with a national focus on health equity, with partners like the National Forum. And alignment in government like perhaps we've never seen before. We have actually committed 3 goals and gotten so serious about them that they have timelines, and we've submitted them to Dr. Walensky, CDC Director. I'm going to read those goals just briefly, and we've added a 4th goal. So the first one is to decrease racial disparities in hypertension control by improving control rates by 5% among Black adults by December 31st, 2024. Goal 2, address surveillance gaps by adapting or influencing existing data systems that capture CVD-related data to collect, monitor, and use metrics on potential drivers of health disparities on all populations by December 31st, 2024. The third goal relates to our work in the Coverdale Stroke Registry. It is to decrease disparities in stroke mortality, morbidity, and treatment by increasing the proportion of women, Black and Hispanic adults with ischemic stroke treatment that receive treatment in a timely way, and improve that by 5% in the Coverdale sites by December 31st, 2024. Our 4th goal is to develop and execute a plan to play our part to improve cardiovascular health in women. We know that we can improve women's cardiovascular health in those other 3 goals, but we want to call out and begin to develop an identity and a set of actions that can contribute to the work that all of you are doing related to women's cardiovascular health. And we need partners to do it. So we look forward to working together. Thanks, John.
Great. Well, thank you very much, Dr. Wright. Great update, and love having those goals with the firm dates. So thank you. Our next update will come from the American Pharmacists Association Foundation, and here to share it with us is our friend Ben Blumel, Senior VP of the American Pharmacists Association Foundation.
Hey, John, thanks so much. Can you hear me okay?
We can hear you well, Ben.
Okay, great. I'm going to start with an acronym, so hopefully you can remember Team APHA from the American Pharmacists Association, and the acronym is Addressing People's Health Through Access. 9 out of 10 Americans live within 5 miles of a community pharmacy, and there are a little over 300 million visits through the front doors of community pharmacies every 7 days in the United States. So access is key. So let me give you a few highlights from the things that we're doing that are focused on reducing cardiovascular and cardiometabolic risk broadly across the entire population. Using our foundation's practice-based research, evidence-based, that demonstrates pharmacists can improve identification and resolution for more than 40% of unmet vaccination needs through the implementation of our Project Impact Vaccine Confidence Initiative with support from the CDC. Our next initiative, Solutions for Atrial Fib Advocacy from the Foundation, is utilizing pharmacies as an access point to screen at-risk populations, identify people who have AFib or abnormal rhythms, and refer them for diagnosis and treatment, and hopefully then on to team-based care over the longer term. Our foundation's 6-year cooperative effort with the CDC to establish and expand a pharmacy-based model that engages pharmacists in becoming a compelling part of the solution for preventing diabetes in the U.S. through expansion of the National Diabetes Prevention Program in priority populations is one of our flagship initiatives currently. In a connected context, APHA is finalizing the release of several new resources that focus on the pharmacist's role in diabetes health management for vulnerable populations, and our public health special interest group is releasing a toolkit to help pharmacists partner with their community and public health initiatives. And finally, APHA's Pharmacy Today article entitled Moving Toward Health Equity, A Journey, discusses how pharmacists can better understand their community's SDOH issues with contemporary examples of workplace health equity and meaningful interventions to integrate diversity, equity, and inclusion. So we're always open to new ideas and opportunities to collaborate at Team APHA as we all endeavor to do more good for those we serve.
Thank you very much, Ben. And I love the acronym. That'll make it easy for us to remember. Thank you. A lot going on at APHA. Now we'll turn back to CDC, this time to the division DNPAO, Division of Nutrition, Physical Activity, and Obesity. And here to give an update is its director, Dr. Ruth Peterson.
Great, thank you, John. As the director of DNPAO, I can say with confidence that we strongly are committed to improving nutrition and access to physical activity across the lifespan to decrease obesity, cardiovascular disease, and other chronic diseases, especially those for racial and ethnic groups who are disproportionately affected. So while obesity is a complex disease with many contributing factors, underlying risks include higher levels of food insecurity, greater access to unhealthy foods, less access to places for physical activity, and inadequate access to health care. The pandemic has only made these things much worse. We've seen sharp increases in BMI changes in children, as documented by a recent CDC report. We've had a significant exacerbation of racial disparities in food insecurity and decreases in the level of physical activity among almost 1/3 of our U.S. adults, with decreases highest among Black and Hispanic adults. All of this underscores the need to address the root causes of these worsening disparities. As part of this work, DNPAO funds state and local governments, land-grant universities, and community organizations to increase healthy eating and active living, again, focusing on populations disproportionately affected. DNPAO is committed to supporting states and communities, facilitating community engagement, implementing evidence-based strategies, and tracking obesity and its risk factors. There's 3 priorities that we have, which include working to improve access to healthy foods by advancing food service guidelines, improving the food supply, and driving demand for healthy foods. The second one is to continue to lead with many of you, Active People, Healthy Nation, which is a national initiative to help 27 million more Americans become more physically active by 2027. And the third priority is reordering community and health system priorities around prevention to include addressing these root causes of disparities, health equity, and community and individual thriving. Thank you, John. I appreciate the opportunity to be here.
Well, thank you, Ruth, very much. That was a lot that you packed in 2 minutes. So we appreciate that. Before we move on to a report from the National Lipid Association, I just want to remind folks that you're welcome to get in line. Just let us know through the Q&A window that you'd like to share what your organization is doing to address one or all of the panel agendas that were sketched out today. We'd love to hear from you. And right now for NLA, we have Dr. Mary Catherine Cheeley representing the organization. So Mary Catherine.
Yes, hello. This is my first National Forum annual meeting that I've been a part of, and it is wonderful. It is really enlightening. I have really enjoyed it. So thank you guys very much for that. From the National Lipid Association standpoint, we are extremely big on prevention of cardiovascular risk and ASCVD. So some of the things that we've been working on in the last little bit and continue to work on are those special populations. So we just published a scientific statement and paper on prevention of ASCVD in South Asians living in the United States and how their risk is different once they move to the United States and now assimilate into the culture here. So that was recently published, and I think really does a good job at helping bring light that there is a different risk assessment for those patients, but then also how providers should treat them differently and look at their risk differently. Last year, we published a paper on coronary calcium scoring, which was kind of a hot button issue back then, thinking of what's a good way to look at prevention, but also kind of a subclinical risk of atherosclerosis, and how to use that scoring to then drive therapy for the patient. Most recently, we published a scientific statement on lipid measurements, which I think everyone thinks, oh, we all know how to look at LDL. We all know how to look at those different measurements. But it was a really good way for us to come back and say, these are the basics of how to treat lipids and therefore how to address patients who are not getting treated appropriately or have this residual risk, which often is our kind of health inequity that we have in some of our lower income patients. And then the last thing that I think is an undefined risk that we've done a really good job and are focusing on is Lp(a). So Lp(a) in the last year or two has really come up as, I wouldn't say a new biomarker, but a different biomarker that often does not even get looked at, period. And so in our lower socioeconomic classes, for instance, in Black patients, we know that risk is higher. We know that their Lp(a) is higher. And so we've done what we can to then go back and teach and educate providers on how to look at that disproportionately to then help our providers treat our patients a little bit better.
Great. Well, thank you very much, Dr. Cheeley. It's really great to have you as a pharmacist representing NLA and demonstrating that lipid control, and as well as generally cardiovascular, cardiometabolic health, is a team-based sport. So
yes,
it takes all of us, all the clinicians, patients, public health as well. So thank you very much.
Thanks.
Our next report will come from the American Heart Association from Juliana Crawford.
Hi. Hey, John, can you hear me?
We can hear you.
Awesome. Thanks so much for having me. So I serve as the Senior Vice President of Consumer and Patient Health at the American Heart Association, and also have the privilege to be a relatively new board member for the National Forum. So really great to be here. The content was amazing today. I think me and our teams have learned so much. And so when I think about the content today and what the American Heart Association is committed to doing, it was about this time last year that we announced a new health impact goal for the organization, and actually to 2024. So it's really a health equity impact goal, and that puts the AHA as becoming champions of health equity at the forefront, and really ensuring that we are all focused, all business units across the associations are focused on identifying and removing barriers. And so this last year has really been about all functions of the AHA thinking about their business plans and ensuring that equity lens is first. And so some of the commitments that we've made, as you can imagine, first and foremost is in increasing our investment in equity and diversity research. And so we have a commitment to accelerate our investments in this area to 2024. We're thinking a lot about diversifying the pipeline of individuals that are going into healthcare related fields. And that, might begin in secondary school when we're focused on STEM programs in communities across the country, but also working with HBCUs and Hispanic serving institutions to award scholarships and professional mentorship and development for folks that are interested to ensure they're getting into healthcare related fields. It's also being infused, of course, into our work in access to healthcare, access to quality healthcare So when we're thinking about programs like Get With The Guidelines and our programs in the outpatient setting, we're focused on rural settings, going into areas where those programs may have not been, so we can decrease gaps in health inequities there. At the community impact level, so with our staff that are working in communities with community health centers and community-based organizations to create linkages and supports, we're really focused on the issues of blood pressure and nutrition security. And then the last thing I think I would mention when I think about that third panel around increasing diagnosis and treatment of mental health issues. A lot of that effort right now from the Heart Association is coming through our workplace channel, where we're updating our workplace health index to include the issues of mental health and health equity. And then finally, I'd be remiss to say, from a policy perspective, of course, we're laser focused on Medicaid expansion. So those are some of the areas I would highlight. We learned a lot today to take back home. Oh, John, I think you're on mute.
Yes, indeed. Thank you. And Juliana, that is a ton that you have going on. So thank you very much for that report. So glad to hear your comments about community health workers in there. Denise Smith, hope you're listening. Hope you heard that. Now we want to turn to Mending Hearts, and we will hear from that organization's executive director, our friend Andrea Baer.
Thank you so much. Nice to be here. Fabulous conversation today, and I've really enjoyed it. I just wanted to highlight what we are working on right now and moving into 2022 is a new approach to peer support, building upon our success in the peer support realm. We're working on building community-based peer support programs to train and empower individuals to be healthcare champions within their local communities. And our goal is to impact the high levels of cardiovascular disease, health disparities, and low health literacy in local underserved communities by using that peer support and community engagement. We will be training, working with local hospitals to provide the education and impacting the patients and the families where they are, which is in their local churches, in community centers, in barbershops, and anywhere in schools. So we can train these champions to kind of put together their support group and support each other in their quest to become healthier, heart healthier, and more active to hopefully the long-term goal would be to reduce those cardiovascular outcomes and improve the health literacy within their communities.
Sounds good, Andrea. Yeah, very quick. That's great. Well, thank you very much, and congratulations on that good work.
Thank you.
All right. Now we will turn to the American College of Preventive Medicine, and representing ACPM is Tanya Gay.
Good afternoon, everyone. So my name is Taja Gay. I work with the American College of Preventive Medicine. It's actually just my second week, so I'm excited to be here with all of you all. So just focusing on some work that we're doing in regards to hypertension prevention. So we have a project that's funded by the CDC's Division of Heart Disease and Hypertension, and stroke prevention. We're focused on the capacity building of health systems and physicians who are working to detect and control hypertension in Black men to address this issue in their areas. So we've just entered into year 3. We have 5 health systems that we're working with. These health systems have been using different ways to drive their initiatives, such as utilizing their nurses and pharmacists, and also some medical residents as well. The goals for this project is basically just to increase the screening, testing, referral of Black men who have hypertension or at risk for hypertension, increasing the engagement of self-measured blood pressure monitoring, and also just breaking down some social determinants of health and some social need barriers that affect the blood pressure control. So multiple grantees have been addressing access to transportation, food insecurity, and health literacy as their social determinants of health. And we also have one grantee who has created a loneliness questionnaire to address social isolation as a social determinant of health as well. And moving forward, some things that we've observed are just the importance of leadership buy-in to address these social needs and social determinants of health, and also the importance of implementing a feedback loop between providers and the entities aiding and addressing the social determinants of health as well. So those are just some things we are working on. And in the future, we plan to discuss the importance of using Z codes with our grantees as well.
All right, very good, Taja. Thank you. Thank you for that report. We're now joined by a co-founder of the National Forum, Dr. David Goff, Division Director at the National Heart, Lung, and Blood Institute. Dr. Goff?
Thank you, John. Clearly, it's a target-rich environment, and that is what we've been hearing today. And we are taking a lot of shots on different goals, and I'll talk about just a couple. First is in the area of COVID. We've been busily supporting clinical trials to try to address some of the host tissue damage related to COVID. We're also setting up cohort studies and leveraging our existing cohort studies to understand the impact of COVID on the population. We've also launched an initiative in collaboration with the National Institute of Minority Health and Health Disparities called the Community Engagement Alliance to really address vaccine hesitancy related to COVID. And we know of the great activities of the forum in that area. And we're now launching an effort to do observational studies, mechanistic studies, and eventually clinical trials related to post-acute sequelae of SARS-CoV-2 infection. In the realm of addressing social determinants of cardiovascular health and health equity, we have several initiatives going on worth mentioning. One is our Decipher initiative in partnership with our Center for Translation Research and Implementation Science, led by a friend of the, well known to the forum, Dr. George Mensa, which is a community-based effort to test strategies to implement effective evidence-based strategies in low resource, high disparity communities. We've also launched a maternal health community implementation program that's similarly guided by community-based participatory research principles and to address maternal health in diversity populations. And we'll be launching next year a home visitation initiative to focus on improving maternal health and hopefully also child health. And I'll close just by mentioning our efforts to nurture the next generation of researchers with diversity in mind. Thanks.
Thank you very much, David. Great report. We appreciate that. Before we go on to our next update, I just want to remind you that if you would like to give an update from your organization, we'll welcome that. And please just let us know in the Q&A box and we'll get you in the queue. So please feel free to step up. Now we have an update from the Wright Care Initiative and its director, Hattie Reese-Hanley. Hattie?
How lovely to see all of you. Let's see if I can just, there we go. Sorry about that interference. I wanted to just say that we're coming up on our 292nd Wright Care University of Best Practices, and that we gather every 2 weeks and we build esprit de corps and we build community. And I love the community that you have built, National Forum. It's absolutely amazing. And it's so uplifting to our spirit, right? For all of us who are passionate about this topic to gather. And that's what we've been doing on a smaller scale in California for really about 15 years. And what I wanted to point out is the women's equity issue that Janet Wright brought up a little while ago. And I think that the key for the Wright Care Initiative is a hopeful message, which is that through using performance data and having transparency and having support for improving performance for LDL 100 blood pressure 140/90, and A1C 8, we actually were able to drive down very quickly acute myocardial infarction hospitalizations. So I want everyone to feel that you can do it. You can do it. Gather your community, give them the transparent data, and work together collaboratively. And you can very quickly, by following evidence-based practices, make a huge difference in your community. I wake up every morning with the number 3,826 fewer acute myocardial infarction hospitalizations. And that gives me a lot of courage to continue with this work. And it's just, I appreciate the opportunity to update you.
Well, thank you, Patty. We really value your work and we're learning a lot from it. And of course, the National Forum loves how inclusive the Right Care Initiative is. And congratulations on 3,826. I mean, that means a lot of dollars saved, and more importantly, it means a lot of people who are vitally engaged with their families and in their communities. So congratulations. That's great. Now we'll move on to our 11th organizational update, and it's going to come from the National Association of County and City Health Officials. Representing NACCHO today is Stephanie Weiss.
Thanks, John. I really enjoyed today's meeting, and I'm already my wheels are turning on how we can incorporate all the learnings into our work at NACCHO. So like John said, I'm Stephanie Weiss from National Association of County and City Health Officials, and we represent the country's over 3,000 health departments. And, just wanted to emphasize our commitment to health equity, as well as increasing capacity and resources for local health departments to address the root causes of disease, both through public health practice and their organizational structure. So first, just wanted to mention one thing that NACCHO has done and developed, which is our Roots of Health Equity course. And this is a free online course that is widely used by the public health community, both health departments, individuals, organizations, partnerships, and coalitions, kind of as a starting place to develop a shared understanding of health equity and informed public health practice. So after my update, I will pop that into the chat so folks can reference that and pass on to your colleagues if you'd like. Also specific to our cardiovascular health work, through our cooperative agreement with CDC, we recently funded our first cohort in a new grant program intended to enhance the work of local health departments and partners working to address health equity and cardiovascular health. And we just closed the RFA for our second cohort, which we're expecting to fund in the next couple of weeks. So we look forward to sharing their stories and successes over the next year or so through a series of webinars, case studies, et cetera. And we'll be sure to share with this group as they develop. So thanks, John.
All right, thank you, Stephanie. That's great. Before we move on to the next person, I want to mention on behalf of Dr. Walter Koroshetz, the director of the National Institute for Neurological Disorders and Stroke, who had to step away a little bit early, that he wanted to share with all of us that understanding the long-term effects of COVID is an important part of the Recover initiative. And if you aren't familiar with Recover, or even if you are and you want to learn more about it, it's easy to find. Just Google NIH Recover Initiative. It's easy to find. So thank you, Dr. Koroshetz, for that update. And now we're going to turn, Julie just put the URL in the chat, so you don't even have to Google it. It's right there for you. And now we're going to move on to Women Heart. And representing Women Heart is Amy Friedrich Karnick. Amy?
Hi, thank you, John. As everyone has said, it's been an amazing day. So thank you so much for all the work you guys put into the speakers and the thoughtfulness to the topics. It's been I think really, really on point for this moment. Women Heart is a patient-centered organization focused on women living with and at risk of heart disease. And I just want to highlight two kind of projects we have going on right now. One is around the issue of missed and delayed diagnosis of heart disease in women, something we've been focused on since the founding of our organization. But we were blessed to have a PCORI grant last year that allowed us to bring together a convening of experts to talk about solutions to the problem of missed and delayed diagnosis. So we released a report earlier this year, which I'll put the link in the chat, that provides many different types of interventions and ideas based on the problems that we see, and suggests research questions, patient-centered research questions that if explored could really lead to some great solutions to the problem. And so we're going to continue to be pushing that issue. We've got some videos coming out shortly with patient stories that we'll be sharing on social media to really engage the patient community, the research community, the clinicians, all of that in this issue, so we can really start to see progress. So that's one. And then the other is around the issue of DEI. Obviously, focusing on communities most impacted by heart disease has been a major goal of Women Heart since we've started, but we're really doubling down on that. We're going to go into next year with new investments in that area, researching, understanding better unmet needs of women in communities most impacted, retraining our Women Heart Champion volunteers on issues of health equity so they can speak with real knowledge and experience when they go out into the community and do their community education and peer support. So we're excited about all of that and the work to come in the next year. Thank you.
Well, thank you very much, Amy. And thanks for all the great work that Women Heart does. So glad that we've had so much comment today as we've been talking about disparities, not only about racial, ethnic, and place-based disparities, but also about gender disparities. It's so important that we close those gaps and not allow them to be tolerated. So thank you for your work. And thanks to the 13 organizations who provided updates. That is really tremendous. And we're proud of the work that you're doing, the actions that you're taking, and look forward to continued collaboration through the remainder of 2021 and 2022.